Good afternoon, everyone, and welcome. It is a pleasure to convene this discussion at such an important moment of global health. Across regions, we are facing increasingly complex realities. Health systems under pressure, demographic transition, shifting economic landscapes, and growing demands from our populations. What is clear is that no country is facing these challenges alone, and no single sector can address them in isolation. This is why these spaces, where we bring together perspectives from governments, academia, and regional organizations, are so important. We are very fortunate to be joined today by distinguished leaders who bring deep experience in shaping and strengthening health systems in our region and beyond. It is my pleasure to welcome Dr. Patricia Garcia from Universidad, Peruana, Cayetano, Heredia, Dr. Joaquin Barnoya, Minister of Public Health and Social Assistance of Guatemala, and Dr. Jarbas Barbosa, Director of the Pan American Health Organization. Thank you all for being here and for contributing to this important conversation. With that, I will invite Dr. Patricia Garcia to guide us into this discussion. Welcome, Patty.
Thank you. Thank you, Ximena. And I have to introduce Ximena. Ximena Garzon is the Dean of the School of Public Health in Ecuador, but she has been also the former Minister of Health of Ecuador. So we are meeting today to discuss the issue of building resilient health systems in a complex global landscape. And actually, all the people that are here, sitting here, represent the Latin American region. But I think that there could be things that we could learn also from the region. So this is a moment of profound complexity for global health. Everybody knows that health systems are still recovering from recent shocks while facing all these new pressures that we know: economic uncertainty, political instability, aging populations, and persistent inequities that continue to shape who gets access to care and who does not. But today, it is not about describing these challenges, because we all know about them and we don't want to get the press. What we need to do is we need to think about what are the solutions. So this session is about solutions. What is working, what can be scaled, and what is standing in the way of really being successful. So we will focus on the discussion on three key areas. First, we want to talk about what interventions can be rapidly scaled to improve health outcomes, but also which ones will take some time. Second, we want to discuss about the barriers, financial, institutional, political, that may limit the implementation. Because if we know the enemies, then we can do the fight. And third, how we move toward more sustainable, locally driven models of financing and action, particularly in Latin America. Latin America has been the forgotten continent. There have been lots of investments in Africa. Asia is investing, but Latin America has been kind of left behind. So we are going to be talking about it too. We also want to broaden the conversation beyond the health sector itself to governance, social determinants, and commercial determinants that cannot be ignored. And because all of them are conditions that truly shape health. So our plan is to have a moderated discussion with brief initial reflections, again, about building resilient health systems in this complex environment. And that will be followed by an interactive exchange and questions, and then time, so you, the audience, can also ask the questions and comment about what we are discussing. So that's kind of how are we going to work this session. And first of all, I would like to invite Dr. Barnoya to start his opening remarks. Dr. Barnoya, please.
Good afternoon. Good afternoon. It's quite an honor to share the space with you guys, and I'm really honored to be here. They asked me to start with a personal note beforehand. So, in a nutshell, I spent 20 years in academia. I've been in Ministry of Health for the past 21 months. I'm not going to compare them, but I'm just going to tell you I didn't have any gray hair during the 20 years I was in academia. You might imagine where this came from. And then the first time I heard the word resilience was from my psychologist, which, by the way, I started when I started being a Minister of Health. So now I'm talking about resilient healthcare system, and I think that's quite of a challenge. Resilience basically means to be flexible. And again, as I said, my psychologist was the first one to mention it. Now, how do we build a healthcare system that can be flexible when nobody has a magic bullet or the eye that can foresee the future? So it's really hard, I can tell, from a personal perspective, to tell what's going to happen on a personal level, but also on a healthcare level. And I think we have several examples. The one that comes to mind is the COVID pandemic, as it was just mentioned, and more recently the measles outbreak that has been happening in the region, and we just in December, the first measles case was diagnosed in Guatemala, and thus far we have around 4,000 cases. It is not only about preparing for pandemics. We know that there's an NCD crisis worldwide, including LMICs, but just recently, Guatemala proposed the resolution in the WHO for CKD to be raised in the priorities. That was not the case 10 years ago. Now it is. Now we have another chronic disease competing with the already catastrophic ones that are struggling in the healthcare system. So it is definitely not only about pandemics. Chronic diseases are definitely there, which will challenge the systems, particularly in early diagnosis, treatment, but also follow-up and the continuum of care, including palliative care. In Guatemala, I mean, if you see what needs to happen in order to build a resilient healthcare system, first of all, you need to prioritize it, to have the political will. I can tell you that is the case with my team and with the government in Guatemala right now. But then you need to have data, and data needs to be really good data, but also needs to be communicated adequately to the policymakers. I don't want to get into details on how data is used in government. Sometimes I think that government is some sort of an evidence-free zone, but we need to push really hard to be using good quality of evidence and adequately communicated within government. And the second part of using this data is making sure you have it. And in healthcare systems like the Guatemalan one, which is not only a fragmented healthcare system, but for the most part with very few data that can be used to plan ahead, not only for the healthcare system, resilient or not, but what's ongoing right now. So having data timely and very well collected is very important. Now the other part that is very important that I believe for building a resilient healthcare system is trust. And I can speak for Guatemala firsthand. Even before the COVID pandemic, the public healthcare system was struggling of regaining or having the trust from the general population. It's just generally seen as the last resource any would be looking for, unless you have low resources or from a rural disadvantaged community, you will look for the healthcare system. But as soon as you start improving your socioeconomic status, the first thing you will do is move away from the public healthcare system. How do we gain back that credibility is fundamental. Now, on specific concrete steps we're taking a look during the current administration, first of all, is making a law, a governmental decree, so that we have a primary care network system. And I don't mean only the primary, secondary, tertiary levels, which is pretty well known, but also a system that can refer up through those levels, but also down from those levels. And making sure that the population recognizes where they need to be treated. At least in Guatemala, unfortunately, patients are now called consumers. The first thing they would look for is for the ER in a tertiary care hospital. How do we change that mindset? That most of the ailments we have can and should be treated at the primary level and then be referred uphill and then downhill if necessary. Second, improving the data collection and data transfer. I agree that technology is a huge step forward, but we need to make sure that whatever we're digitalizing, it's good quality of data, and it's not we're digitalizing corruption. We were briefly describing the corruption amongst Latin American countries. I don't think there's any country in the world that is free of corruption. That is a huge cancer within the system that needs to be solved. Availability of medications and affordability of medications is quite a challenge. I agree there are very good treatments for chronic diseases, but most of them are very expensive. And the gold standard is sometimes just this much better than the substandard, if I might call it. And we're pushing very hard for the gold standard, which is very expensive. We also need to look back to that substandard treatment because sometimes it's just more cost effective, particularly in LMICs. Finally, I think there's a lot of push for AI and the digitalizing of the healthcare system. I do agree, we support it. However, it should not be seen as the magic bullet, because otherwise it could just create a larger gap between the ups and downs from society. So I'm gonna stop right there, I'm not sure. Oh, the one last point is that yes, we do have a fragmented healthcare system, but maybe it's also a result of our fragmented society. At least in Guatemala, it is not only the healthcare system that is fragmented, the government itself, it is fragmented. We need to stop thinking about the Ministry of Health as a vertical line, and we need to talk about healthcare as a horizontal line that crosses all over government, not only obviously the central government, but also Congress and of course the judicial system as well. Thank you.
Thank you so much. Okay, so we are starting talking now. We are talking about how resilient systems should be flexible to respond to all the needs, and that there is a need of having leadership, data, but it's also important to have trust. And that technology could help, but we have to be careful of not creating more inequities and be sure that the data that we collect and use is data that has good quality. So from the perspective, it's more like the lens of the Latin American region, Dr. Jarbas. How do you approach this issue of building resilient health systems in this complex world?
Thank you. Good afternoon. Thank you for inviting me to participate. Let me briefly, for the ones that are not familiar, the Pan American Health Organization is a double organization. PAHO was created in 1902, so we are the oldest public health international agency in the world. When the World Health Organization was created in 1948, PAHO and WHO signed an agreement so that PAHO also represents WHO for the Americas. And leading the health sector in the Americas is not easy because we are the most diverse region in the world. We have at the same time the richest country in the world, that is the US, and we have a country like Haiti that now we can see for several years now that even basic services are they are struggling to provide the basic health services to their population. But within the countries, we know that this label of middle-income countries, the average, in reality, they are not telling the whole truth. They are not telling the very important pockets of poverty, extreme poverty that we have in the countries in Latin America and the Caribbean. They are not telling the truth about the vulnerable groups that don't have access due to several different barriers, not only the economic barriers that are the most important to have access to health service, but also social and cultural barriers. If a person from an indigenous population goes to a hospital, or emergency room, or a primary health care center, and don't understand or is not respected, probably they will not be back. So we are talking about a very complex scenario. Despite all these challenges, the Americas is a leader in public health. The annual report that is published by UNICEF and WHO is clearly showing that we are the region that is recovering faster from the negative impact that the pandemic produced in the immunization coverage. We have already reached the same level that we were in 2019, but of course we are not happy with that. We need to move forward and we have to reach the proper immunization coverage that we needed to stop the current outbreaks of measles in Canada, in Mexico, in the US, Minister Barnoya mentioned in Guatemala and in other countries. Also, another example, we have only 18 countries in the world that were certified to have interrupting mother-to-child transmission of HIV. 12 are in the Americas, and in a couple of weeks we will be 13, because Bahamas was already certified by the external committee that reviewed the data. So we are at the same time a region that has a lot of challenges, and grand part of my job is exactly to do what Patricia mentioned, to call the attention that Latin America and the Caribbean, they need to receive support. Some of the global mechanisms that were created in the last 20 years, they think that the middle-income countries don't need support, and this is not true. And we really need to ensure that all the countries receive the support they deserve. And I am convinced that some initiatives that we implement in Latin America and the Caribbean can inspire and can also lessons that can be shared with other regions. For example, we have a very close collaboration with the African CDC. We are sharing with them how to strengthen surveillance, how to move forward for digital transformation, how to establish a regional procurement mechanism like we have in the Americas. We have two funds, one for vaccines and one for medicines and medical devices that make our countries being able to have access to high-quality health technologies, pay a more affordable price. So I think that in this scenario that we have now, that was, I think, that very well summarized, the rapid demographic transition, the high cost of the new technologies, I do believe that the resilience is very linked to adaptation, that the movement that you need to implement in the countries, to implement the lessons that you learn from the pandemic, how we need to be better prepared, not only for a future pandemic, but to deal with the current challenge that you have. In 2024, we had 13 million cases of dengue. The emergency rooms in several countries were totally overwhelmed with the dengue cases, the dengue outbreaks. We are talking about the needs that you have for the situation now, but also that clearly primary health care, renewed and strengthened. A primary health care that is not only focused on maternal and child health, but that can provide and can deliver health promotion, surveillance, response, prevention, and be adapted to the current complex epidemiological scenario that we have in the region, while some communicable diseases persist, and the non-communicable diseases are a very important burden, not only by the proportion that they have. They are around the 80% of the total deaths. But what really is unacceptable is that 34% of these deaths could be prevented. Could be prevented if we were able to monitor, to detect, and to provide the access for people with hypertension, for instance. So this complex scenario that you have in mental health and all this complex scenario, if you don't implement a health system and health services that are based in this renewed primary health care, I think that we don't have a resilient health system that can, during a crisis, a local crisis or a global or a regional crisis, can be able to keep the services open, can utilize the new tools, telemedicine, telehealth, artificial intelligence, in order to keep the service providing the care that people have, and also being able to identify what are the barriers in order to use health to be a promoter of equity. I think that this is the challenge that I see now. Thank you.
Whoa. Applause. Yeah. So Dr. Jarbas has really summarized several things regarding Latin America that I just want to stress. So Latin America is the most unequal region in the world. And most people don't know that, but it is. And we do have indigenous populations, and that has been stressed from PAHO and from the level of the countries. So we think about what we call the cultural sensitive services, because we can lose the opportunity to give the services if we do not understand the culture from where people are coming. One interesting example is, for example, the vertical delivery system that in Andean countries has been established, that it started in Peru. So we knew that women were not coming to services because they were told that they have to lay down and open their legs to have their babies, when culturally the best way was to deliver standing up, holding, and having the family around them. So now we have services that allowed you to choose in which way you would like to deliver. So with all the challenges, Latin America has been a champion in vaccination. COVID has been a problem because, I mean, it really damaged most of our services. However, we're catching up. And that probably is one lesson about resilience. There are excellent examples like the strategic funds for vaccines and the regional procurement mechanisms that have been created. But still, to be resilient, we need to work on strengthening primary care, not only for infectious diseases and maternal health, that is working, so also to try to strengthen how to redesign the systems for non-communicable diseases, for mental health, non-communicable diseases in general. And technology could be used. These are all great things. So going back to what has happened, what is one lesson from the recent crisis that we should carry forward to build more resilient health systems, Dr. Barnoya?
One lesson and recent crisis, I mean, they have so many crises. I hope you're referring to the COVID one, because
yeah,
we have some
the huge crisis.
One lesson, I guess everybody realized that we need data. Private sector, government, NGOs, we all need data within countries and between countries. We also need, well, that's the one lesson. I'm gonna add more lessons there. Health communication. It's very important. In general, physicians, I'm a physician, we're very poor for communicating health risks, health outcomes. We need better health communication. Government officials are also very poor for communicating healthcare issues. We have several examples, including in the US. Vaccines, even though how quickly they were implemented, how quickly they were adopted, they also generated and probably highlighted the anti-vaccine movement. I don't want to say for or against, but certainly vaccines became a hot topic again. And some of that is what we're looking right now with the measles outbreak, at least in Guatemala, that the trust in vaccines was really harmed during the pandemic. And then evidence-based medicine. How quickly or how much evidence do we need in order that we take clinical actions? We saw the ivermectin, chlorine. Nobody knew exactly how to treat COVID. I don't know, we know thus far. I'm not a clinician, but I think that's something we need to continuously be evaluating. Obviously, we need the case control data, the cohort data, randomized clinical trial, but data takes a long time. And diseases are not waiting there for the best case to show up, and or the meta-analysis or the systematic review. And I think we continuously need to be challenging academia on how is it that we change clinical practice or change or change public policy. I did more than one lesson, I guess.
Thank you. Dr. Jarbas, the same question.
No, thank you. First, I fully agree with Minister Barnoya. I will not repeat, but just to show how data was important, I think that at least 3 ministers were fired during the pandemic because they couldn't tell the population, the society, how many deaths and cases happened last week, how many people are in hospital beds or in UCI beds now. So I think that this is really important. I think that, of course, talking about the big one, the COVID-19, COVID-19 changed the way that we approached prevention and preparation for public health crisis. I think that we need to build on this new concept, new ways, but also in something that we are building during the pandemic. I will just tell you one example. genomic surveillance before the pandemic was only performed in the US and in Canada, in our region. Now we have a network of 30 countries in Latin America and the Caribbean that they have national capacity, and they are using this not only to follow up the seasonal flu virus, to have a rapid detection if a virus evolves to another thing, but also to monitor the viruses that are important for the region, chikungunya, Zika, dengue, and others. I think that is also important. What it changed was this idea that the services they need to be able to deliver care even during a public health crisis. Countries that have very good data, we really see that the excess mortality for cancer, cardiovascular diseases, and all the other causes because the services were closed or were very limited during the pandemic. So I think that this is a lesson that we need to work together now, thinking about how we can have first a better use of the technology that are already available. Telehealth and telemedicine were already available during the COVID, but there was a lot of prejudice, there was a lot of lack of preparation to use them. But also thinking about how we can move to this system that is more integrated, primary health care, the specialized services, but also how primary health care can have the human resource, not only number, but the right training to be most capable to address the problems that the population have, from pregnancy among adolescents to mental health, to better care for non-communicable diseases, to how to advance elimination of cervical cancer and other diseases, but at the same time to be the best way, or the best channel, the best path, if a person needs to move to a specialized service. If we don't do that, I think that we are losing, because people will go to emergency rooms, they will crowd the emergency rooms, they wait 6-8 hours, because they don't trust that the primary health care is the best channel. And if trust is crucial. If they don't trust with the concrete results, I think that we will not win this game.
Well, thank you, Dr. Barbosa. I'm going to wrap up a little bit what you, the experts, have said. Definitely, Latin America has a huge gap, extremely poor people and extremely rich people. And in that gap, we are misclassified as countries that are not doing so bad, that need help from the world, and we really need the support. And I really appreciate what PAHO has been doing during all these years, supporting the countries. Ecuador was one of the countries that had a lot of support during the pandemics, technical support. But we really need to strengthen the epidemiological surveillance in our region to prevent what happened during the pandemic in our countries. We still are facing a lot of problems with dengue, yellow fever, and other infectious diseases, but also chronic diseases are doing a lot of damage in our populations. Renal chronic disease, hypertension, diabetes, and a lot of other important diseases that are also related with environmental health, with environmental pollution. And I think that that's something that we also have to face together. As you said before, the lack of health professionals, not just nurses or physicians, but also experts in epidemiology and public health are needed in our region. So what does a truly resilient health system look like in 5 to 10 years? And what can we do today to advance in that direction? Connecting all of these needs to equity, implementation, technology, and local capacity. Please, Dr. Joaquin, could you address the question?
Yeah, that's kind of a challenging question. Definitely healthcare network that includes obviously the primary, secondary, and tertiary levels, but that can actually is a network that people would get referred from one level to the other, and as I said, backwards from the high levels to the primary care level. However, I think we need several things to happen for that to happen, if I may say. First of all, you briefly mentioned we need to change the workforce. Thus far, it's a very specialized and super specialized healthcare workforce that we have. It's really, I was just talking to them in the podcast we were recording about how little trendy primary care is in general, worldwide, as opposed to pediatric cardiology, pediatric cardiac surgery. If you see the specialties, they're not, I mean, everybody becomes super specialized now, not only specialized, but super specialized. So I think if we want a resilient healthcare system, we also need to change how the workforce is trained. As you mentioned, not only physicians, but nurses, social workers, and so on and so forth. I would hope to see also a system that is not only illness-centered, but more so commercial determinants of health and risk factors center as well. I think we need to be taking into account, obviously we have a tobacco epidemic that is still ongoing. We never solved the tobacco epidemic, even though we have the FCTC, but now we have emerging products, flavored cigarettes, heated tobacco products, electronic cigarettes, you name it, but then also ultra-processed food and the way we're eating. The major NCDs are determined on those risk factors. We do not get sick in the healthcare system, we get sick in the community. Therefore, that network has to be embedded in the community as opposed to outside of the community, and communities should also be involved in building that network. I think academia is going to play a huge role on designing that resilient healthcare system that should be around for at least 10 years, and urbanization, the uncontrollable, undesigned, or excuse me, that's not a word, the lack of a projected, programmatic urbanization process, I think that's also going to take a toll in the healthcare system, not only in Latin America, but worldwide.
Thank you so much. And what do you think about it, Dr.
Thank
Barbosa?
you, Ximena. I fully agree. Minister Barnoya calling the attention about the healthcare workers. We estimated that by the year 2030, we will have a shortage of at least 600,000 healthcare workers. Only think about the number, because when you go within the country to see the distribution, most of the healthcare workers are concentrated in the capitals, and for some current and future needs that we have, we really need to rethink the way that we are the medical nursing schools, the residency programs are really preparing these professionals for the challenge that you have now. I think that thinking about this future that you invited us to reflect, I think that first we need to build on some concrete experiences. I just yesterday came back from the One Health Summit in France, and I was very happy because I participated in several sessions sharing some concrete experience that we have in the region. We have, for instance, we have a committee that was established some years ago that brings together the public and the private sector and the different aspects, the environmental health, human health, animal health, to deal with the outbreaks of avian flu that we have had in this region for several years. We are also using the same methodology to strengthen our capacity to identify epizootic events in selvatic areas in order to prevent yellow fever cases, because now we can see for several reasons yellow fever cases outside the traditional area that was happening in the last 2-3 decades, and probably this will be the scenario for the next year. But moving to the non-communicable diseases, hypertension is probably the condition that is most important for deaths among adults. You know, the average in our region is that only 25% of people with hypertension have the hypertension controlled. Only 25%. In countries, and I'm not talking about the rich countries, in countries like El Salvador and Dominican Republic, that we supported the Ministry of Health to implement a comprehensive package that's called Hearts for the Americas, this proportion is around 60%. 60, from 25 to 6%. So, because this we are talking about certified equipment to monitor hypertension, we are talking about training, we are talking about indicators to follow up, we are talking a comprehensive way to handle hypertension, not only the medicine, but also health promotion. So I think that we need to build on this experience, concrete experience that we have, in order to adapt them to different national contexts, because in Guatemala is not the same thing in Mexico or Brazil or in Nicaragua, but clearly that if we build on this, in this experience that we already have in the region, I think that we are moving in the right direction to remove barriers, to promote more equitable access, to put really in practice what is universal health and coverage and access in this region, and to be more able to respond to this diverse epidemiological scenario that we have. So when I look to the near future in 5 or 10 years, I think that the resilient health systems will be the system that will be able to perform this adaptation in a more sustainable way.
So, this question about how does a truly resilient health system will look, from what you are saying is should be a health system that is responsive, that has providers that are able to solve the problems, right? That is close to the community, that is trusted by the community, and that is in relation with all the different sectors around, not just health. And that is something that we need to start working on. And there are some pilots, I would call it pilots or models, that are trying to bring health systems into that, especially strengthening primary care. So now we enter into that. I mean, what are those solutions that you see today that could be scaled up quickly to improve, or could be scaled up to improve health outcomes? And what are the barriers to implement those solutions? So this dream of having resilient health systems could happen. Dr. Barnoya.
The scaling up, I think it depends a lot on what is it that you're trying to tackle. I think the cervical cancer is a good example. At least in Guatemala, the pap smear has not worked so far. We obviously need to look for alternatives. We have the DNA HPV testing, which we have data that it is culturally sensitive and appropriate for the rural population in Guatemala. So as opposed to be pilot testing it, we need to implement it, and it's gonna take time. And obviously we're doing the vaccine. The vaccine is absolutely a really good strategy, but it's gonna pay in 10 years. And in those 10 years, we're gonna have women that are still gonna be getting sick, they're still gonna be getting cervical cancer. So I think that obviously vaccine is the way to go, but in the meantime, the vaccine, we see the benefits of the vaccine, we'll still have to have the strategy to take care of those women that are still gonna be struggling with the disease. So I mean, scaling up, it's once you're in office, you realize that the scaling up, I'm not gonna see it for sure, somebody else will have to, because it takes time. Everything in government takes time. I used to complain about the pre-review process, how long it takes. Oh, now that I'm in government, I mean, pre-review process is nothing. If you try to change policy, wow, then you get the gray hair. So I think barriers, there's plenty of them. I think politics is about facing the barriers and looking how to get across those barriers from top or above, I don't know, get across those barriers. However, that's where academia should be taking place, on how to foresee those barriers and how to look alternatives so that those barriers can be overcome. I think it also depends on the context where we're talking about. Guatemala, and I can speak firsthand, I could consider the country a failed state. Congress is a big part of it. It's not only about ministers, it's about Congress as well, and corruption. As I briefly mentioned, we were talking in the beginning before the panel started, corruption is a huge part of governments, and I say plural, and unfortunately money moves back and forth in government, and that needs to stop. But I'm not sure I'm answering your question, by the way. Best Buys and low-hanging fruits, it's a moving target. And it also depends on how can we prioritize not when people are doing politics. Obviously, I come from the tobacco field. I could never raise taxes because that's not politically feasible right now. Obviously, I can speak up on tobacco control as a minister, but I could not get it to the level of Congress because thus far they will not pay, politically speaking. So how do we juggle with those between our own agenda and when it's politically feasible? I think that's what we'll need to be challenging constantly.
Thank you. So you were talking about the example of cervical cancer, and I want to bring that back. So Peru, for example, introduced HPV molecular testing, but in order to bring it closer to women, that's when we started to involve community health agents. And this new way of promoting the testing, which is self-sampling. So self-sampling, now the country is buying HPV tests. It's promoting self-sampling. Community health agents, which are women, talking with other women about how to do that, are there. But we had to talk about barriers too. And the barriers are the physicians who are complaining or are against or feel that they could lose power because women are taking their own samples. And also OBGYNs that are concerned that means that women are not going to go to their offices, and that's where they get a lot of services. So, but that means that we need to work and realize what could be those possible barriers. So, Dr. Jarbas, what about, again, what solutions do you think should be scaled today? We have talked about vaccines, cervical cancer, and what are the barriers?
No, thank you. The most important barrier is the economic barrier. When we see the region in Haiti, for instance, that the population still have to pay out of pocket a very important part of their treatment. We have by far the worst coverage of everything, antenatal care, hypertension treatment, cancer detection, everything. But as I think that you mentioned, I mentioned this too, we have also other barriers. We have sometimes immunization. Immunization centers that are open only Monday to Friday, 9 to 5. Probably this, I don't know, 30, 40 years ago, when the families had one person that could bring the children during the day to the health center to be vaccinated was good, but now this is a barrier. This is a barrier because with the new vaccines that you have introduced, a person, and in general is a woman, because 50% of the poorest families in the region has only one adult that brings some income to the family, and this adult is a woman. And in general, she's working in the informal sector of the economy, so she's not allowed to have 10 to 12 days to bring the child to the vaccination room if everything goes well, if the vaccine is there every time, if the service is open, etc. So if you don't have strategies that can be adapted to reduce this barrier, open in the nights in neighborhoods that are safe, open in Saturdays or Sundays, using new strategies to identify, like micro-planning, that is one strategy that we are working together with the countries to identify where are the non-vaccinated, so we can listen to their communities, identify what are the barriers, to have a strategy to overcome, then we cannot, I think, that address this kind of challenge. So I think that one problem that you have, and I am a public health worker, so I'm not criticizing anybody, I'm criticizing myself too. We are very conservative. We want to do the same thing that we do for the last 10 or 20 years. Public health programs, sometimes, they have an extraordinary success because that strategy is adapted to that moment. 10, 12 years ago, if they continue repeating the same thing, if they don't identify what are the barriers in order to establish specific strategies to overcome that barriers, the strategy that was a success probably will be a failure. And this is happening in several areas. how we can get the access to people living in homelessness situation, to get them access to HIV diagnosis and treatment, how we can move mental health care from hospitals to primary health care in order to reduce stigma and discrimination, so we can reduce the unacceptable award that we have, the Americas became the region with the highest suicide rate in the world. And the suicide rate increased in the last 2 decades. And in some countries, this needs to be a combination of moving from hospitals to primary health care, but at the same time moving legislation. Because in some countries in the region, suicide attempt is still a crime. So the family doesn't want to communicate with the health sector because they are afraid that the person that attempted suicide and survived will be facing a problem with the police. So the best way that I think is really to understand what is changing, what are these new realities, the new barriers that were created. You mentioned an excellent example, HPV. We believe that the cervical cancer can be eliminated, and the Americas can be the first region to eliminate. We have only 3 countries among the 51 countries and territories in this region that have not introduced the HPV vaccine yet. But even countries that have introduced vaccine in the last 20 years, they don't have a strategy that can reach the adolescents. They are vaccinating at health centers, and adolescents, they don't go to health centers, so they are wasting a very important tool. With the consolidating the regional demand, we were able to reduce the price of molecular tests from $25, that was the average price, to $15, $13, and I do believe that we need to get them below $10. If we work together. But we also need to provide the treatment for the lesions at the primary health care, because if a woman receives the result that she has something but needs to wait 6 months, 1 year, going 3, 4, 5 times to a specialized center, this is another barrier that are clearly in front of us and we are not addressing. So I think that we need to be skeptical. We need to think that we can do something better, we can renew, we can adapt. We need to listen to the communities in order to have this flexible way to adapt the strategy to the realities that we have nowadays.
Thank you, Dr. Jarbas. We are seeing that we are facing many challenges. Internal violence, lack of opportunities for female, inequity, and we have also to move from working in silos to a more coordinated and efficient health system. We are facing also unstable politics, corruption in our countries, and we are facing other challenges such as aging and also environmental pollution that could be related with this huge amount of people that are trying to take the life of themselves, because they could be affected by the environmental pollutions like metals, heavy metals, and pesticides and everything. So we have to take everything into account, and when we are ministers of health, we have to face all those challenges. So I want to ask 2 questions, one for Dr. Barnoya and another one for Dr. Barbosa. Dr. Barnoya, from your experience as minister, what were the biggest barriers that you faced? And what needs to change so future leaders can overcome them? What did you face in government that is low implementation? What barriers are structural versus political?
I'm going to start with the last one, with the structural and political. I think those go hand in hand, because the politics determine the structure, and sometimes the structure will not change unless the politics change. With the barrier, I think the unpredictable, how politics and how the political scenario is unpredictable, I think that's the main one, and I think it depends a lot on the team you're working with that will actually be doing like the hands-on work, the public health work, and I do the political part that I have to handle. So building a strong public health team is fundamental to overcome those barriers. I face barriers from Congress, impeachment, external barriers, internal barriers within communities. It's the healthcare system. I mean, the Ministry of Health is a complicated system in itself. We don't only provide healthcare, but we oversee manufacturing, registries, authorizations, clinical trials, you name it. We see cemeteries, you name it. Everything that has some food registries, food security, clean water, sanitation, all of that falls within the Ministry of Health. And that, obviously, the main one is healthcare provision. Unfortunately, again, that's where we judged against. And in general, the system will recognize very little if you think outside of the box beyond providing healthcare. So I think that's the largest barrier. Oh, the other part, unfortunately, that also a barrier are unions. The Ministry of Health has 70,000 employees approximately. We have 52 unions. And I'm not against unions, but unfortunately, unions have been manipulated in Guatemala, and now they have become not only a source of corruption, but also a source of corruption with the drug manufacturers. So within that, I think my role is to face those barriers while my team that is working on the public health issues are doing their work.
Thank you so much, Dr. Barnoya. I think that we learned when we studied public health how to face the technical issues of the job as Minister of Health, but we didn't learn how to face the political and the inequity and the violence and perhaps the corruption that we have faced in our countries. So, Dr. Barbosa, in an increasingly complex geopolitical environment, with shifting alliances, economic uncertainty, and competing global priorities, how is PAHO adapting with the context of a changing global health architecture and landscape?
Thank you for this question. First, I want to recognize Minister Barnoya as a champion. He's leading a revolution in Guatemala, improving the quality of care, improving the quality of primary health care, bringing telehealth and telemedicine for hundreds of centers. And I think that's a very good example is this combination of an excellent technical background with the commitment and the leadership that we really need to make things in the region. The global scenario is really challenging because we have now several countries that reduce their budget for international aid, for humanitarian aid. So even all the mechanisms, I say all the international organization mechanisms are thinking how to adapt. In PAHO, we started thinking about this a couple of years ago, so we have implemented several measures to increase the efficiency of our organization. We established new partnerships around the world to be less dependent on only one country or a small group of countries. So I think that we are trying to make our homework in order to be more transparent, more efficient, more accountable, to clearly show to the member states and the citizens in these member states that pay the taxes from where they pay the assessed contribution to PAHO, we are providing the best use for each cent that we receive. At the same time, it's important to call the attention, and I think that this was said more than one time, but it's never, we can never miss an opportunity to call the attention for the inequalities that we have in this region. So I think that when we are talking about the inequalities here, we don't want to compete with another region. We know that the situation in Africa is terrible. It's terrible because sometimes the health systems in several countries in Africa cannot provide the basic access. But at the same time, if some things that we are implementing in the region can be part of this global solidarity, because they can be lessons that the African countries can understand it, can adapt it to their reality, and can inspire them to move better. Last year, Suriname became the first country in the Amazon basin to be certificated as having eliminated malaria. It was a huge achievement. And it was important because how they achieved that? Because in Suriname, we changed the way, the problem of malaria, that was a very conservative one. You had to go to a health center to get the diagnosis, the treatment. But the problem was concentrated in Minister Barnoya and professors in their illegal mining activities. And illegal miners, they don't want to go to a health center because they are afraid to go there and to go to prison. So we trained the miners, we trained the communities, we gave access to them to diagnose, rapid diagnosis, the new tools that we have, because sometimes the new technologies are not enough. If you don't change the strategy, if you don't adapt the strategy, probably we will not provide the best use for them. And this was crucial to achieve the elimination of malaria. I could go for several different examples, but really I do believe that we have a lot of things that are moving on, challenges that are huge, systems that are still underfinanced. We estimate that we should have around 6% of the GDP as public health expenditure. The average in the region is 4.3%, so we are talking about a challenge for the Ministry of Health, like Minister Barnoya. But at the same time, to have a productive dialogue, including with the Ministry of Finance, we need to present proposals that are effective, that will provide the best use for the limited resources that the countries have. And I think that strengthening primary health care, making primary health care capable to solve the problems of the population, to be listen to the community, identifying, removing barriers is the best way to move forward.
Excellent. And you all know that this is a conference of the consortium of universities. So we have academics here. So, and this is a question for you both, Dr. Jarbas and Dr. Barnoya. So what do you see should be the role of universities? What will be the role that they should play in health systems resilience? Or how academia can better support governments in addressing all the problems and the barriers? Is there a space for academia? Or how can academia work, or how is it working already in countries like Guatemala, for example, and in other countries?
Thank you. There's a quote attributed to Kissinger, who was asked about the difference between academia and government, has said, well, he said, in academia, the passions are high, the stakes are low. While in government, the stakes are high, the passions are low. I'm trying to keep my passions low now. And I guess first of all, academia, it's not a one-size-fits-all. A lot of Latin American countries have very little academia, as we understand it. We would like, at least in the case of Guatemala, that universities would be dedicated to generating ideas and looking for solutions for social problems, in this case, health problems. That's not the case for most of the universities in Guatemala. However, I think it's very important there's a strong and continuous communication between policymakers, government officials, and academia, because the more academia dedicates to finding solutions to those problems and evaluating them and helping us figure out the outcomes and how they're measured and evaluated over time, I think that communication should be continuous and very fluent and genuine and honest. Now, how does that happen when government officials often change? As Dr. Barbosa said, by the way, I'm the third Minister of Health in the current administration. I'm not sure for how long I'm going to last. But that instability of the political system, I think that also challenges the academia on how and who do we communicate with, taking into account that, again, government also includes Congress, different ministers, not only ministers of health, but as Dr. Barbosa mentioned, ministers of finance, ministers of labor, and so on and so forth. So I guess that's one of the challenges, and how do we communicate back and forth, not only to look for the problems, look for the solutions, but also communicating in a timely manner the findings.
Dr. Barbosa.
No, thank you. Thank you. Minister, you are lucky because you have already survived the infant mortality rate among ministers of health. That is very high in this region because most of them don't can celebrate the 5th anniversary. So you are already having extra time, let's say so, but you are providing a wonderful use of this time. Academic institutions in this region, they play a very important role. They are very committed to increase the access, to guarantee and to build a universal health system. So I think that we also have very, very good examples and good lessons from the academic institution. We have a network of 150 collaborating centers in the region, but most of them are based in the US and in Canada. And we are now trying to expand this network of centers because the idea of a collaborating center is that it is an academic institution, it's a very strong technical background, but at the same time it's providing concrete collaboration to solve problems, to offer solutions. Because I always tell my team there that we need to have the evidence to show to Minister Barnoya and the other ministers to say, to make the case for a public health problem, let's say maternal mortality. But after showing all the data, all the evidence, the minister say, okay, I agree with you. Now this is my priority. Tell me what are the 3 things that I need to implement to reduce maternal mortality in my country by 50% in 1 year. If we don't have these solutions to present, we will not be trusted when we talk with a minister about the problem. So I think that this is the main contribution that I see, that working together, not only to have a better diagnostic about the problems, to understand not only the biological health problem, but also the social, economic, commercial, environment determinants of health, but also what are the best options that we have to remove barriers, to overcome barriers, to guarantee access, and to expedite the way that we are providing better health and well-being for the population in Latin America.
Thank you so much. And yes, probably this is something that other regions could learn from Latin America. There are very good relations usually between universities and the health sector, helping not only to identify those solutions that are already proven that could work, but how to implement them. And even before the word implementation science was coined, we were doing implementation science. And that is something that is critical. And you wanted to add also something, right?
Well, yeah, briefly training the healthcare workforce. Beyond the healthcare providers, we need epidemiologists, public health practitioners. I have 2 PhDs working in the Ministry of Health. I mean, that's nonsense. We would like to have more, but there's not one PhD in public health in the whole entire country. So from a university perspective, thinking beyond the healthcare providers. And if we're going to do healthcare reform, we also need to reform the the medical school curriculums.
Thank you so much. So we have discussed several things, and we were trying to give you like a context of Latin America. But now I would like to open the session for questions. And I cannot see that well, but I think there is one person there. See, how are we going to handle this, with mics or?
I'll go here if you want. Yes.
Okay, yes, please.
Yeah, sorry, I was actually not going to shift.
If you can identify yourself and maybe direct the question.
Sure, I'm not going to shift to other Latin America y voy a hacer la pregunta en inglés para que me entiendan. Un gusto a todos. Carlos Faerrun de la Universidad de Maryland, Baltimore, pero soy costarricense. Now I'm going to shift back to English. Now we often think of resilience of something that is internal to countries. However, I think we learned from the pandemic that resilience also depends on external actors, be it information coming from the US, places like Hopkins, technology coming from China, Germany, even India, or Russia were creating their own vaccines that got distributed in Latin America. So just want to ask, given current geopolitical shifts and a decreasing trust in the United States and kind of a, let's call it a revival of America First policy, I'm wondering how you are seeing how that is changing the landscape of what health system resilience means in Latin America. So thanks.
Let's take another one.
Can you hear me okay? Yeah.
Yes.
My name is Philip Angelides. I'm an internal medicine and pediatric physician at the University of Colorado, but I spend about half the year in Coatepeque in Guatemala, working on implementation of point-of-care ultrasound in a rural public hospital. And so I wanted to actually address everyone on the panel, including Dr. Garcia and Dr. Garzon-Villalba, about really the elephant in the room, which I think is the inequality that you were talking about in Latin America. And I wanted to go from really the conceptual theory that you have talked about to some concrete policies that you've seen within your governments that have worked on decentralization and aiding those populations, especially those ones that goes to the public hospitals and the public sector in your countries.
Thank you. Would you like to start?
Sure. On the resilience on the healthcare system, I think we need to look beyond the Ministry of Health. That includes the Minister of Foreign Affairs, Minister of Finance, and so on and so forth. How we work between each of the ministers, but also how the Minister of Foreign Affairs deals with the geopolitical changes, but stay focused on what we can do down to the Ministry of Health, collaborating with the other ministers of the government. And that would touch upon as well with the inequalities. I am a Minister of Health. Obviously, I have to face the inequalities of healthcare provision, but inequalities of the government in the country, that goes way beyond the Ministry of Health, and that's where we need a horizontal approach rather than just a vertical approach about seeing the healthcare inequalities, because they definitely started with socioeconomical inequalities that resulted in healthcare inequalities.
Yes, thank you for the two very important questions. Carlos, I fully agree that we cannot think about any country isolated being able to be protected. If we see what is the real world, we run a regional surveillance system in the region that 24/7 looks for any signal or word like outbreak, fever, unknown disease, blah, blah, in social media, everywhere. Last year, we identified 1.2 million signals like this, and we supported countries to address 120 public health emergencies. Hanta virus outbreak, dengue, Zika, chikungunya, measles, yellow fever, you can name it. So this is a platform, a transparent platform that all the countries from Canada to Argentina share and receive information. This cannot be replaced by any bilateral agreements with countries. Of course, the bilateral agreements, Canada, and Nicaragua, US, and Haiti, it's important and it's good for the country, but this will never replace this idea that you need to work together in a totally transparent way, in equal basis, in order to be able to protect each one of the countries, but at the same time to protect the region and the world. And Felipe, if I understood correctly, this topic of inequality is really important. As I mentioned, it's important to not think about the averages. It's important to think about the data that can be disaggregated. Is crucial for every country in the region, so we can identify who is being left behind. And knowing that, we can try to identify what are the root causes of this inequality. And from the health sector, but as the minister said, working together with the other sectors, how we can address these barriers and we can address these inequalities.
Thank you so much. Unfortunately, I'm being said that we have very few minutes, and so we have to start wrapping up. I know that you were standing there. This has been a very exciting discussion. Today we have heard clearly that resilience is not just about resources. It is about decisions, it's about leadership, it's about accountability, data, it's about trust. But we have heard also, as part of one of the questions, that it may not be just about countries. we may need to think about regional responses. I mean, there has been discussions about regional technological autonomy also to be able to respond. So we invite you to continue this conversation after the break and also to keep going into this conversation in Lima at the CUGH 2027, where we will try to move from discussion to transformation. And with that, let me invite you, I mean, I have heard that a lot of people like the video, but some of you didn't have the chance to see it. So let me show you again the short video, but let me tell you that we will be discussing a lot about how to go into that transformation that we really need. Can you show the video, please?
Hello, I am a Huaco, guardian of the memory of the Mochi culture, a civilization of artisans, warriors, and dreamers that flourished over 1,300 years ago on the northern coast of Peru. Today, I awaken to celebrate a meaningful moment, your journey toward the 18th annual conference of the Consortium of Universities for Global Health in Lima, February 2027. Transforming global health, partnerships, power, leadership, and technology in a rapidly changing world. This gathering comes to Latin America for the first time and reflects something powerful, a true commitment to collaboration, equity, and the future of global health. And Peru will be the place where many stories begin. Here, you will experience unforgettable firsts, the sunrise gilding the Andes, your first toast with a pisco sour, your first ceviche by the Pacific Ocean. You will walk among archaeological sites that whisper centuries of history, fly over lines that still defy imagination, and discover the grandeur of Machu Picchu. You will also feel the pulse of our ancient music and dances. We welcome you to Lima, a city open to the sea and to the world, where this great gathering will spark new ideas and create memories that will stay with you forever.
For 17 years, the CUGH Annual Conference has brought the global health community together. Now, we enter a new era. In February 2027, Lima, Peru will host this historic meeting under the theme Transforming Global Health, Partnerships, Power, and Technology in a Rapidly Changing World. For the first time, the conference will be held outside the United States, making CUGH truly global. We look forward to welcoming you to Peru, a country where history lives and where its culture, heritage, and world-renowned cuisine are all waiting for you. Mark the date. See you in Lima.
Well, thank you, Patty. It was an amazing video. I really want to go to Lima next year. So thanks, everybody. Thanks to the speakers and the audience. And I'm just going to give a little message. I think that what Dr. Jarbas just said, if we keep doing the same, we will keep getting the same results. So let's think about it. And thank you, everybody, for attending this session. Thank you so much.